Okay, let's start this final part of the issues and trends section, and then on this part we are going to be focusing on performance improvement, which will involve quality improvement and quality assurance, risk management, and risk reduction. I should have just said all of that right there, but here you go, creating performance improvement. And now let's actually get it started. So the first part of this is going to be quality improvement. And this is an ongoing process that should be happening all of the time. It's not as if you first do continual analysis and then do product evaluation and then error prevention and then customer satisfaction. Ultimately, all four of these different components is an ongoing continuous process. They're just continually looping over and over and over again. And each one of these processes will be discussed in a little bit more detail, but ultimately this is the way that we hopefully manage and improve the quality of care that we're giving in our hospitals today. So this quality improvement process, this is a fairly wordy slide that I don't have a whole lot to add beyond what is actually written up there. But it's important to understand that we have to have a process in place, that is that continuous loop like we were just talking about. And in order for this process to work, there needs to be a certain amount, or really rather a large amount, of staff ownership in order for it to be successful. This quality improvement response process cannot be something that is done just by the leader of the unit. It has to be done by the folks who are working at the bedside. Otherwise, we'll never truly achieve the outcomes that we're trying to achieve. So within this process, you need to assign responsibilities and delineate the scope of practice of all the individuals involved who are working on your unit. If you don't adequately, accurately, and publicly, is probably important too, define the scope of practices of each of the individuals who work on your team, you're going to end up getting into a blame game of that's not my job, that's their job kind of aspect, and that's not going to help when we're trying to do this quality improvement process. Then we need to, as a group, hopefully, identify what are our care priorities and establish an evaluation process to make sure that we're doing what we say we're going to do. We of course need to collect and organize the data, and then we need to evaluate the whole process. When we evaluate the data that we've collected, hopefully we will figure out a plan that we need to do. So we're going to decide on what actions need to be taken, and then of course we need to evaluate the effectiveness of those actions that we took, and then we need to communicate the results. Hopefully this will help us identify any breakdowns that happen in communication, and then we can document the client care and results of the interventions that this process did. So you can see it is really a continuous and kind of ongoing process that involves much similar steps as our nursing process does. So if you can just remember your nursing process and handle any problem you encounter, whether it's within patient care or not, that nursing process system will kind of get you on the right track no matter which way you're going. So how do you determine what needs to have quality improvement done? I mean, like, what are the issues on the unit? How do you make these decisions? And ultimately, as the leader of the unit, you have a responsibility to assess the area in which you're working and determine ways to improve the care, right? That's kind of part of the job of this manager or this leader. And I'll tell you, one of the best places to look for information about what needs improvement is to go talk to your patients, right? Information that we gather directly from the clients that we have on a unit actually have the greatest effect in identifying what quality improvement efforts we should make. Because really, honestly, isn't it what it's all about? Isn't that why we are there? To make sure that our patients are getting the care that they need in the safest, most efficient manner that they can. And the patients themselves have a lot of really great ideas on what needs to be done. One of the ways we do that, I think we've discussed this already before in other ways, is that as a manager on a nursing unit, I used to have to do what we call daily patient satisfaction rounds, and that meant that I went around to each room and introduced myself as the manager or the director of that unit, and I actually spent a few minutes talking with the patients while they were still in our care at the hospital to determine how their care has been given according to them. And ideally, this is going to do a couple of different things. I mean, hopefully at the end of the day it'll actually improve our patient satisfaction scores, but truthfully we're trying to deal with the problems as they arise and not let the folks go home without any of their needs not being met. The other thing to keep in mind as we do this quality improvement process, and this is one of the problems we actually have a lot of times within nursing, is that we seem to think that we can do this alone. And we're not alone in this healthcare team, so we need to make sure when we're going through these process improvements that we involve all the people who need to be involved. I've actually seen times when we've worked really hard at solving a solution, go figure, solving a problem, and we come up with what we think is a really good solution, but yet we forgot to involve a very key member of the team who had a key role in the process we were trying to improve. And wouldn't you know, when we go through that process without the right players at the table, the process that we design to make it better often fails. So make sure we have the right players at the table. Okay, when you're going through the process of doing some kind of quality improvement, you want to have a certain mechanism of how you attack each problem. You want to have a plan in place. And this PDSA is one of the data collection tools that we can use when we are planning quality improvement. You plan, you do, you study, and you act. Okay? So really this PDSA tool assists us by asking us three really key questions. What change are we trying to accomplish? How will the change be assessed to determine if there was truly an improvement? And what change is needed that will improve the results? Okay, so what do we need to do? How are we going to measure it? And once we measure it and we reevaluate, what are we going to do now? I apologize, guys. The allergies are getting me really bad today. Some of the things when we look for this process improvement, some other tools, we can kind of have three categories that problems fall into. Or three, I shouldn't say problems, three categories that the tools that we are going to use to address the problem fall into. The first is a process description, and these are things like flowcharts and cause and effect diagrams. These are really helpful, especially when you have a lot of different members of the healthcare team at the table. They may not truly realize how their individual piece of the puzzle fits into the entire picture, and having some of these process descriptions help clarify the roles and responsibilities of each of the members, and therefore helps us understand the entire process to maybe see where some of the problems really are lying. We've got lots of data collection tools. We've got data sheets, check sheets, spreadsheets, things like that. And then we also want to have some tools to help us analyze the data, and oftentimes very visual tools like bar graphs, pie charts, Pareto designs or diagrams, things along those lines that help us visualize the data that we've collected. Some of the resources that you have available to you as nurses and nursing students are these various websites that you can actually go to, and these will help establish the standards of care. If you're having to write papers, especially those of you who are planning on going on for your bachelor's immediately, these are some great resources. So you might want to kind of tag this page in your slides or put it aside somewhere wherever you put handy dandy websites, because this will give you a lot of really good information. Obviously the ANA do the standards and parameters for nursing practice. The National Quality Forum actually develops sets of conditions that should never happen. So these are the things we never want to see. And the goal of this organization is to enable national quality measures and reporting, just so that we are not looking at the data of our own hospital in a silo. We can look at it a bigger picture across the country. We've talked in the past a bit about CMS. CMS is the Centers for Medicare and Medicaid. And really ultimately they have been the driver of so much of our reimbursement, and so they develop and implement pay for performance initiatives that support quality improvement. So this is some of the things where if you acquire a hospital-based infection or a hospital-acquired infection during your hospitalization, CMS won't refund or reimburse, I shouldn't even say refund, reimburse you for the services given. That's CMS. So always helpful to know what CMS is looking at on the horizon, because sometimes it's just something that is being done within CMS itself, but it will quickly translate to a bigger picture with all of the different insurance companies and reimbursement agencies following suit. The AHRQ, Agency for Healthcare Resource, actually has a wealth of information. We call it a clearinghouse, where there's the quality measures and quality tools. So when you're looking to do a quality improvement project, the AHRQ probably has a tool to measure whatever it is you're looking at doing. Joint Commission, I think all of us are aware of Joint Commission. Joint Commission actually has their national patient safety goals, and it behooves you, honestly, before you guys start going into the interview process, if you've not already started that, to kind of have some knowledge or awareness of what the most current national patient safety goals are. But the point of Joint Commission is to accredit hospitals, and when they are JCAHO accredited, it says that they are a safe institution. If you are JCAHO accredited, you actually have to report to the Joint Commission any of your sentinel events and near misses so that they can track this from a broader perspective, and they will actually put out sentinel alerts, is what they call them, and that's when they see trends across the country of things that are happening. So some of the sentinel alerts that I can recall in my area of practice was one about jaundice in newborns and hyperbilirubinemia, and they actually put out a sentinel alert that didn't tell us as the hospital how we needed to track and monitor this. It just said you need to track and monitor this. And out of that sentinel alert that came for hyperbilirubinemia was born the processes where we actually assess the bilirubin level on all newborns in one way, shape, or form prior to discharge from the hospital. And if you can recall back to your OB rotation where there was something called the transcutaneous bilimeter, it's a very non-invasive approach where you can actually punch 3 times, not really punch, but push down 3 times on like the chest wall or the forehead of the infant and get a somewhat accurate bili level through the skin without having to actually do a blood test. And then depending on what that blood test was would depend on what we would do, or what that TCB result was would depend on whether we'd actually do a blood test from that point. You've also got things like the National Committee on Quality Assurance, and this measures the quality of nations' managed care plans, so it kind of looks at the insurance companies themselves. There's also something called a Leapfrog Group, which is actually a coalition of purchasers that provides specific strategies for some of the big metro hospitals. And they've ultimately developed quality index of 27, what they consider to be safe practices that they're making public to people. So sometimes that's a good source of information if you would need it. So some tools that you might need to manage and improve quality. Again, don't forget that quality management is actually a system. When something goes wrong, it's usually a flaw in the system. So remember, we've talked about this again quite a bit in class this past week, or coming up, depending on when we're listening to these, that typically when things go wrong, it is the process, not the person. Now, there are always going to be times when you've got a person who just doesn't follow standard of care, but typically when things go wrong, it's not related to one individual. We got to remember that although we strive for perfection, that's obviously always our goal, we need to be prepared to tolerate failure in order to encourage innovation. So if you think about that for a minute, if we didn't have our failures, we'd never improve or change. So the goal a lot of times when you think of quality improvement in the performance improvement process is really to look at what's not going well so that we can fix it and improve it. So sometimes there's actually benefit in messing up. Who would ever think that your mistakes would be valuable? But they are, because think about even in your own learning. You learn more oftentimes from what you mess up and the mistakes you make than the things you do right. And that's ultimately what we're trying to say here is that we're striving to do it all perfect, but we need to learn to embrace our mistakes so that we can continue to improve. The other thing that's really important to keep in mind is when bad things happen, a caring attitude is almost the best prevention from lawsuit or further problems. There's actually been a lot of research that's been done on this, and it's more natural and easy for nurses to do than it is for physicians, but there's actually a lot of training out there available to physicians on how to become better at this. There used to be a theory or a mindset that said if you said you were sorry for something bad that happened, a sentinel event, a death, or something, whatever that something is, if you said you were sorry, it meant you were accepting blame. And that's not the case at all. And there's actually something to be said about the power of a touch, a hug, some tears, just the fact that you understand that the situation the family is in is a really cruddy situation. And the more empathetic we are, the more caring we seem, the less likely there's going to be a lawsuit after whatever that sentinel event or bad event or mishap was that happened. So it's not an easy thing to get used to doing, but it is a really important thing and a really valuable thing when we actually take the time to do it well. The other thing, sorry, was going to switch the slide and realize there was one more thing I wanted to say. The other thing that needs to happen, so they kind of consider it a tool for managing and improving quality, is performance appraisals and incident reports. We've talked about those already. Cannot be used for discipline. So think about that. If you fear that the information you put in when you're doing a reflection part of your performance appraisal, or when you're identifying where you think, as the nurse involved in the situation, what went wrong in your incident report, if you were fearful that those would come back and bite you in the butt later, and there would be some disciplinary action based on your honesty, you won't be honest. So you need to have an environment where it is safe to be honest, especially in those tools. So quality assurance is a little bit different side than quality improvement. So if you think about it, quality improvement, we had a problem and we wanted to fix it. Quality assurance says, we had a problem, we fixed it, but now we need to make sure we keep doing it. So while quality improvement kind of has a finite start and finish in some aspects, you could potentially argue it's never done, right? But there is a process, right? It starts and it finishes, and you move on with life. Quality assurance is that whole process where we try to ensure that the things and the changes we made in our quality improvements are continuing to be done. Okay? Some of the things, if you think about it, when you've had some QI initiatives maybe in your past or in your experience working in the hospitals, when we just do that QI process, like one of the QI process often is fall rates in hospitals. Our fall rates have increased, we need to work on decreasing them. So then we go through this whole process, and in my time I've actually managed some of these teams that were doing these quality improvements, and one of the things we did was look at fall rates. So we looked at the fall rates, we dived into the research and the literature, and we discovered how other facilities had been successful in decreasing their fall rates, and we implemented many of those processes. You hang a sign on the door. One of the facilities I worked at, it was falling leaves, like the leaves of the fall season, and that would indicate to anyone who walked in that room a very visual cue that that patient was a fall risk. We've used armbands, we've used bed alarms, we've used vests, we've used all kinds of different things, low-lying beds, non-skid socks. I mean, there's a whole realm of stuff that we have done. When we're first instituting the process, it goes really well. People are doing all the things we've said. And then as you get further and further and further away from the actual process improvement point, then we suddenly slack off. It's kind of like when you say posture, everyone stands up straight, and 5 minutes later you look out again and everyone's starting to slump again. Quality assurance is the process we take to ensure that that does not happen. The way to do that typically, or one of your best tools for doing that, is actually doing chart reviews. So you will find that when you're working as a nurse, you may be assigned to do so many chart reviews a month, where you're looking to see if certain key things that have been the result of quality improvement processes are being done and being documented that they're being done. Okay? Again, in order for any of this stuff to work, we actually have to have a culture of safety. And again, I know we've talked about this in the past, but I cannot enforce it enough, is that transparency is the key. Without it, we will truly never be able to develop a culture of safety. Again, where we've talked about some of the methods and how to go about this, we need to describe to staff what errors need to be reported so that we can maintain that transparent culture. We need to encourage the staff to report and support those who report near misses as well as adverse events. And near misses is when it almost went wrong, but we stopped it in time. And there is actually a tremendous amount that we can learn from diving into those near misses, just as much as we can, and maybe more so because we didn't have an adverse event. So there was no negative consequence to the near miss. So we need to make sure that we are not just exploring the bad things that happen, but the almost things that happen. We need to make sure that as a leader, we are being very clear about safety and what our expectations are for safety. And we need a process in place where we can maintain ongoing feedback and maintain that ongoing transparency. When you have that kind of environment or that kind of culture set up on your unit, it truly reduces the fear and the anxiety that punishment's going to occur when errors happen, and that'll further enhance and support that transparent culture. The other thing that we need to keep in mind is that we can actually use our clients kind of as a safety check. So the clients themselves can be that check that let us know that we're doing what we need to be doing, as well as that they can be a part of preventing mistakes and errors. So think about it. So many patients have no clue what kind of pills they're taking, what the medications are, and things along those lines. And they'll just tell you at night, I know I take a little white one, a big pink one, in the morning I take something that's purple. That doesn't give us a clue what medications there are. So if we help them understand and know which medications they're taking, what the meds look like, know the side effects, and that they're ultimately, as the patient, responsible for communicating that to us. And when they see us giving them a medicine that doesn't look like one they're used to taking, stopping us and asking us, why are they now taking a yellow pill? They've never had a yellow pill before. What is that yellow pill? And sometimes it's a new order, but obviously it goes to show that we didn't communicate on what their order changes had been. And either way, we need to do some education. Or potentially we have the wrong patient's pills in our hand and are about ready to make a med error. So patients can actually be a really good safety check for us. All right. Risk management is the next part that we're going to discuss a little bit. And just like the name implies, risk management manages the risks once they have occurred. Okay? Typically, there is a risk management department at the hospital, and it oversees the entire hospital. I know within our area, we actually have many of you guys who are going to be working in the futures when you graduate and a part of SSM. SSM no longer has a risk manager at each facility, but they have a risk manager over certain hospitals. So they're a tool and they're a department, typically at least a person, if not a whole department, and their whole job is to analyze problems that have already occurred and minimize the losses that we might face because of the problem that occurred. Okay, so they identify and define some of the circumstances of the financial risk, because we know there is certainly a financial risk to any mistake we make within the hospital because we can be sued. They're going to assess and determine the frequency of the occurrence of whatever that circumstance was, because they've got the bird's eye view. They can see the big picture. They can see that there is not just medication errors happening on this one unit, but actually hospital-wide or system-wide, depending on what we're talking about. There's a problem with our IV pumps, and so we need to pull those pumps from use, and we need to get some training or need to get a patch in or an upgrade or a whatever to prevent that problem. So they've got that overview of the entire hospital and or system. They investigate and they intervene on any events that are involved in that circumstance. They actually do a lot of exploration and fact finding to try and figure out where the problem's truly happening. And then once they've done that, they actually, if there's not a problem to solve at that minute, there's not been a risk that needs to be managed right then and there, their other part of their job, truthfully, is to identify areas of potential risk and see if they can figure out ways to improve care so that potential risk does not happen. But risk managers sometimes seem scary and seem like you don't want to go talk to them, or if they call you, you start shaking and wondering what you've done wrong. But I have found over my years of working in the hospital systems that they're some of my best friends. And I actually seek out the risk managers that I work with and seek their advice and just befriend them so that I have their support when I need them. If you would ever be in the unfortunate situation of having to do a deposition for care you have administered, your risk manager is actually the one who's going to coordinate all of that, and they're going to talk you through the process and connect you with your lawyers and all that kind of good stuff. So they're there to help you. Although they are looking for potential holes within the system and problems that might happen, they're truly there to help you. Let's talk about risk reduction. And with risk reduction, unlike risk management, which is actually managing risks that have already occurred or problems that have happened, risk reduction is kind of the flip side to the risk manager's job, and they're trying to prevent risks from happening. So they are going to hopefully change the behaviors that will prevent some foreseeable risks, and the ultimate focus is always on client safety. Hospitals actually, by their accrediting agencies, are required to have some sort of program that identifies risk reductions, or that is looking at this process as a big picture thing. When you're looking at that required program, there are things called a failure mode analysis or effects and critical analysis that they can use to dive into an event that has occurred, and it helps them identify where the problem may be. If you're Joint Commission accredited, Joint Commission has in the past, and I believe it's still a true thing, states that at least once a year the hospital has to look at one high-risk process that's identified by Joint Commission, and they actually have many of those high-risk processes that they say are high-risk, low-volume, meaning that there's a lot of potential for mistakes within that process, and we don't do them very often. I mean, like, we don't do the process very often. So that actually makes the chance of a risk occurring even greater. Because when it's in a high risk, low volume, it means we as nurses at the bedside are not used to seeing this issue or problem that often, which increases the overall risk of the process. So they want us to look at one of those every year and identify the potential risks that are inherent in that and see if we can't solve them. And sorry, sidetracked by something else. One of the things that we can do, whether it's a true event that's already happened or something that we think might happen, is a process called a root cause analysis. And when you think about RCAs, or root cause analysis, what we're doing in that process is a retrospective study. So we're looking backwards at an event that has already happened, or an incident, and we're trying to identify the sequence of events that led to that mishap or mistake or whatever it was that occurred. And I've often heard risk managers describe this as lining up the holes in the Swiss cheese, because mistakes don't typically, we have enough stopgapes, we have enough safety checks in place that prevent the mistake from actually happening. But when the mistake actually happens, it is thought that all the holes in the Swiss cheese lined up at the same time, which shouldn't typically happen in Swiss cheese, to allow that mistake to occur. So when you're doing a root cause analysis, you're kind of looking backwards at the process to try and prevent from happening. Alright, so that's going to end this section. Thanks.